Well, over the course of my career, I saw a lot of these studies being published about trust, and I had gotten interested in understanding what factors might either increase or decrease trust in these ethnic groups. So I want to spend a little bit of time talking about what we know about those things. So one of the studies we did many years ago was we used data from the Commonwealth Fund Healthcare Quality Survey, nationally representative survey that actually oversampled ethnic minority communities and asked a lot of questions about experiences in healthcare. But these are the questions that we focused on. We wanted to understand more about how ethnic minorities perceived the fairness of their care, whether they felt that they were being treated differently by physicians and whether the healthcare system treated them differently. So actually, when we looked at care by physicians, we did find racial and ethnic disparities, but a lot of those could be accounted for by things like education and how long or how well they knew the physician, whether or not they had a regular source of care, and other qualities of the doctor-patient relationship, like the communication that took place in the visit. So we were able to explain the large part of racial disparities in perceptions of biased treatment by physicians by looking at those factors. But in contrast, when we asked about being treated in a biased manner in the healthcare system, we weren't able to explain away that by anything, actually. So what you can see here is that significantly larger percentage of African Americans, Hispanics, and Asians reported that they feel that they would have been treated better if they were of a different race or ethnicity, or that they were treated unfairly based on their race or ethnic group, but also on how they spoke English. And I thought this was even interesting that even among African Americans who, for the most part, reported English to be their native language, that they also felt that they were treated in a biased manner based on how they spoke English. So we know that if people perceive that they're being treated disrespectfully or with bias, that's been shown to be associated with low trust as well. The other thing we did was then to really try to get inside the doctor-patient relationship. And so we looked, basically because we knew that there have been other studies in larger populations showing that a better doctor-patient relationship and communication predicted better trust. So in this one study that we did in Baltimore, we looked at African Americans and whites, and we actually found that African Americans and Hispanics reported less participation in decisions about their care. And when we used audio tape analysis where we recorded primary care visits, we actually found that physicians were more verbally dominant, meaning that they actually talked more of the time when they were talking to minority patients, and they sounded less friendly and interested as rated by independent coders of the audio tapes. The other thing we found is that positive physician affect or friendliness tone as rated by an independent coder was a significant predictor of high trust. But this relationship was even stronger among African Americans than it was among whites. So we got interested in looking at racial or ethnic concordance between doctors and patients, and there's been a growing literature in this area as well. So several of my colleagues have done studies in this area. This particular study is a study that we did in Baltimore where we used pre-visit and post-visit surveys and audio tape analysis. And what we found was that in visits where the doctor and patient shared racial background, the visits were longer. They were about 2.5 minutes longer. Both the doctor and the patient sounded more relaxed and friendly and interested in the visit. And there was more participatory decision-making in those visits, as well as higher satisfaction reported by patients. We also did another study where we looked at concordance across a variety of different dimensions. So not just race, but also gender, age, and education. And we found that with increasing concordance, there were cumulative benefits on communication as well as on patient ratings of care. Now, none of this is that surprising, right? But it is worrisome, given the fact that we know that most ethnic minority patients are not going to be able to choose a physician of their same racial or ethnic group. We also know that we shouldn't really let ourselves off the hook, right? Why should we absolve ourselves of the responsibility to be able to communicate more effectively across differences when our society is becoming increasingly diverse?